So a very good day to one and all. I am Dr. Rohit Gopinath, and today we'll be discussing about a very important topic, swellings. This particular topic is not only important from the clinical point of view, but also from the theory point of view. So you can expect a lot of questions as far as theory paper is concerned in relation to swellings. Not to mention that it is an important short case in clinical exams as well. So before we go into this topic in detail, it is very much essential that we understand the basic meaning, or we should understand this basic meaning of these three important words, swelling. So what exactly is swelling? Swelling is an enlargement of a part of the body, and the cause for this enlargement can be anything. It can be either inflammatory, it can be neoplastic, it can be traumatic, it can be infective, whatever it is. But the criteria is that a swelling should be well defined. Mass. Now, definition of a mass is a lesion whose extent is difficult to assess. For example, if I have an intra-abdominal mass, it is very difficult to exactly assess and measure the extent of the lesion or the lesion. So, what is a lump? That's the third important word. So, these three terminologies are what we encounter commonly in day-to-day practice. So, a lump is defined as a lesion noted within an organ or causing an alteration in the gross nature and shape of a part or an organ itself. For example, if you have a breast lump. So, when you have a lump within an organ, so the organ here is the breast. So, if you have a lump or a lesion within an organ, which is going to cause a distortion in the physical architecture and shape of that organ in which that lesion is present. So, breast lump, like I said earlier, is the most common lump that we encounter. So, before we proceed further, it is very important that we have a basic understanding regarding these three important terminologies. What is a swelling, what is a mass, and what is a lump? So, let's now go on to the first swelling, which is a lipoma. So, lipoma is a benign swelling arising from yellow fat. So, the terminology yellow fat means that it denotes mature adipocytes or adult fat. So, mature adipocytes have a normal nuclei and they are commonly seen in adult fat. The most important characteristic of mature adipocytes is that this fat does not take part in general metabolism. So, when a person tends to lose weight over a period of time, the body fat content might reduce, but these lipomas do not reduce in size because they do not take part in general metabolism. It is the most common benign tumor with an incidence of 2.1 per 100 people. It is called as an universal or ubiquitous tumor because it occurs in all areas except the brain. It can be localized or diffused. So, if it is localized, you find that it is well encapsulated with an yellowish orange color. If it is diffuse, you find this capsule may not be present. It is usually seen in those areas wherein it can extend further, extend deep, and it can extend over a large area. For example, like the head and neck region. In the soles, because there are tense fascia, the swelling may not be apparent very well. Palms, etc. So, it can be subcutaneous or it can be intramuscular as well. Lipomas can be superficial or deep. Superficial lipomas are the ones that we commonly encounter. They are seen in the back, neck, and extremities. They are usually smaller in size compared to deep lipomas, and which are usually around 5 centimeters, less than 5 centimeters. Deep lipomas are commonly intramuscular lipomas, very commonly seen in the lower limbs, trunk, and shoulder. They can extend to large sizes because they are not easily noticed in the beginning stages, and they are more common among men when compared to women. Lipomas can also be single in nature or it can be multiple. Single lipomas are more common. Multiple lipomas can occur in 15% cases, are commonly associated with Men's syndrome, Cowden syndrome, Froelich and Proteus syndromes. There is an entity called multiple lipomatosis, wherein you have a young person with a familial history of lipomas. You have multiple lipomas occurring commonly in the shoulder and the pelvic girdle. And this familial association is noted in 30% cases. Another very important terminology that we might come across with regard to lipoma is liposa dolorosa. So basically it's also called Dercum's disease. Very common among females with a history of epileptic and psychiatric disorders, characterized by multiple lipomas which are usually tender in nature, commonly occurring in the trunk and in the pelvic girdle. So these are few images which depict how a lipoma looks like. So this is a large lipoma you can see here, which is located along the medial border of the left scapula. And this here is also a lipoma. So it might look like a papilloma or a pedunculated swelling. So lipomas can also be pedunculated. So that is what I like to convey here. So this is a pedunculated lipoma. And the most important characteristic of a pedunculated lipoma is that it is susceptible for surface changes. So you can see here there's an ulceration here. So pedunculated lipomas, particularly in areas which come under a lot of traction, friction, etc., are very much prone for skin related changes like ulcerations. So this is an individual with multiple lipomas. Now, if you have a lipoma arising from brown fat, it is characteristically called a hyperoma. So it is characterized by the presence of serpentine vascular elements. Now, even though the most common swelling is a lipoma which contains only fat, sometimes you can have non-lipomatous components in it as well. Hence, the most common non-lipomatous component of a lipoma is fibrous tissue, and in such cases the lesions are called fibrolipomas. Now, if you have a lipoma with telangiectasia, it is called as a nevolipoma. Other types of lipomas or variants of lipomas are angiolipoma if it has a blood vessel inside, neurolipoma if it has neural tissue, myolipoma if it has muscle fibers, etc. So others are chondroid lipoma and pleomorphic lipoma. When you have a lipoma arising from immature fat cells, it is no longer called a lipoma, it is called a lipoblastoma. Now, when you have a lipoma within a joint or within a tendon sheet or within the synovium, then it is called as a lipoma arborescens. Now, malignant transformation of a lipoma is virtually non-existent. Why? Because lipoma arises from mature adipocytes, whereas malignancies like liposarcoma come from primitive mesenchymal cells. So this image here is an MRI showing the presence of a lipoma extending into the joint capsule. So this is a lipoma arborescens. This is an image of a lipoma, MRI image of a lipoma in the gluteal region, and this is an example of a lipoblastoma. So what are the clinical features of a lipoma? So a swelling can be thought to be a lipoma if it has a lobular surface characteristic, non-tender, localized, maybe diffuse also, but commonly it is localized. A very important characteristic of a lipoma is the presence of pseudofluctuation. It might seem as if it's fluctuant, but it may not be actually fluctuant. It is because sometimes fat might have liquid components in it as well. So it might exhibit a phenomenon called pseudofluctuation. Ideally, these swellings are non-transilluminant, might show little bit of mild transillumination if the fat is liquefied. But generally, the dictum is they are non-transilluminant. They show the presence of a characteristic slip sign. When you run your finger over the edge of the swelling slips away from you, which is called slip sign positivity. Since these are lesions which are located deep to the skin, commonly in the subcutaneous plane, skin is usually free and pinchable. It is to be noted that lipomas are rare in children. So that is the last diagnosis that you would come to in a child with a subcutaneous swelling. So investigating a lipoma is mainly required if you are suspecting a deep, large or an intracavity lipoma. Imaging modalities which might be useful includes an ultrasound. Here you can see an ultrasonic description of a lesion which is located in the subcutaneous plane. And this here is an MRI image showing the presence of a lipoma deep to the skin but superficial to the vertebra, possibly in the paravertebral muscles extending into the subcutaneous plane. So in an MRI, characteristically, lipomas are hyperintense. Even in T1 and T2 weighted images, they are hyperintense. But in stir images, they tend to be hypointense. So what are the common complications that are associated with lipomas? Common complications include myxomatous changes, which are very common among retroperitoneal lipomas. Saponification, and as a result of that, calcification can occur in 11%. If a lipoma is found to have calcification, it should raise the suspicion of the presence of a liposarcoma, because calcifications are very common in liposarcoma. So this is an X-ray image of an individual with a subcutaneous swelling, which was found to be firm to hard in consistency with dilated veins. And when an X-ray was taken, it was found that there were multiple calcifications noted within the lesion. In the end, it turned out to be a liposarcoma. Submucosal lipomas, very common in the gut, are known to cause intestinal obstruction by causing an intussusception. Liposarcoma commonly occurs in the retroperitoneum, in the thigh or in the back. They exhibit rapid growth, can have dilated veins over them. There's infiltration into deeper planes and there is skin involvement, and metastasis can occur commonly to the lungs. The treatment of any lipoma is excision. If it is a localized single lipoma, then the chance of recurrence is pretty less. But if you have a diffuse lipoma, then the chances are that there could be an incomplete excision, and in such cases, recurrence rate is as high as 11%. When you have multiple lipomas, it may not be possible to excise each and every lipoma. So those lipomas which are causing symptoms in the form of either pain or restriction of movements, or there's cosmetic disfigurement, so these lesions are usually excised, where the others are not done so. Now, let's go on to the other group of swellings called cysts. Cysts are basically a collection of fluid in a sac lined by an epithelium or endothelium. They come from the Greek word cystis, which means bladder. Cysts can be true cysts or false cysts, based on whether there is a lining epithelium or not. A common example of a false cyst would be a pancreatic pseudocyst. Post-pancreatic pancreatitis, as a sequelae, you can have a peripancreatic collection which gets organized over a period of time with an epithelial with a pseudocapsule forming a pseudocyst. So that is a common example of a false cyst. Other common examples of false cysts include what is called as an apoplectic cyst. So apoplectic cyst occurs in the brain following an ischemic event. Following an ischemic event, there is liquefaction and formation of a cyst. So cysts can be classified into congenital cysts, acquired cysts, cystic tumors, traumatic cyst, degenerative cysts, and parasitic cysts. So this here is another example of a false cyst, which is a traumatic cyst. So following trauma, what happens is that there occurs a hematoma. So once a hematoma occurs, the RBCs within the hematoma tends to get lysed and absorbed, leaving behind clear fluid or fluid with some areas of clots. So this here is an example of a traumatic pseudocyst. Clinical features which are generally seen in cystic lesions are they are hemispherical in nature, can have a smooth surface, might be fluctuant, usually non-tender. Transillumination can be present in cystic lesions, but it is not a dictum that it should be present in all lesions. Symptoms with regard to cysts depend upon the site and the pathology. They can be single or they can be multiple in nature. So this here is a demonstration of a cystic lesion in the angle of the mouth, which shows transillumination positivity. So what are the effects of a cyst? Like I said earlier, certain symptoms with regard to cyst depend upon the location of the cyst and the pathology behind the cyst. So a cyst can cause compression of adjacent structures. A common example of this is a choledochal cyst. When you have a choledochal cyst, which involves the biliary apparatus, most commonly the extrahepatic biliary tree, it can cause compression of adjacent structures and cause symptoms. Another example is a pseudocyst of pancreas, which can cause compression on the bowel, can cause compression on the biliary tree, can cause compression on the adjacent vascular structures, etc. Infection. A cyst can actually present itself as an abscess because of secondary infection. Torsion. A cyst can undergo torsion, especially if it arises from a pedunculated structure. For example, like the ovaries. Ovarian cyst predisposing to a torsion is a common phenomenon. Calcification can occur in cyst. Sometimes a cyst can have hemorrhagic areas, can have areas which are more prone for dystrophic calcification. Cachexia. Cachexia with regard to a cystic lesion can occur if the cyst is malignant in nature, commonly ovarian malignant tumors, testicular malignancies, etc. or retroperitoneal cystic malignancies, etc. Now, what we need to know are that there are certain swellings which exhibit a phenomenon called brilliantly transilluminant. So these swellings which are brilliantly transilluminant are ranula, cystic hygroma, epididymal cyst. In an epididymal cyst, it has a characteristic name called a Chinese lantern pattern. So this is the demonstration of an epididymal cyst showing transillumination, and you can compare it to a Chinese lantern. Hydroceles can also be brilliantly transilluminant along with a meningocele. Now, a very important cystic lesion that we come across on a day-to-day basis are dermoids. So dermoids, there are different types of dermoids. Commonly encountered ones are called sequestration dermoids. So these sequestration dermoids are congenital in nature and occur along lines of embryonic fusion because of invagination of the epithelium deep within, causing a nidus for a cyst formation. When it occurs in the scalp or in the skull, it is prone for an intracranial extension. When it occurs in the external angular region, it can extend into the orbit. Based on the scalp dermoids, based on the extent of the lesion, can be divided into type 1, type 2, 3 and 4. 1 is a cyst located outside the skull. That is, there is no intracranial invasion and there is no indentation onto the skull table or the calvarium. 2 can be again divided into 2A and 2B. 2A is a cyst with a bony indentation. 2B is a cyst with a dural involvement. 3 is a dumbbell dermoid, wherein you have a component which is located subcutaneously and another component which is intracranial. 4 is a purely intracranial dermoid, which is extremely rare. So these are certain common sites of dermoid. So this is an external angular dermoid. We already saw a scalp dermoid. So this is an external angular dermoid. And this is a suprasternal dermoid, commonly called a suprasternal dermoid, which arises from the space of Burns. Commonly, these dermoids, sequestration dermoids in particular, contain a putty-like material which is formed by desquamated epithelium, hair, sebaceous and sweat glands. They are usually painless unless and until there is secondary infection, and they exhibit a phenomenon called Paget's test positivity, which is again used to demonstrate fluctuation. So in Paget's test, you find that the swelling is held between two fingers, and when you apply pressure at the center of the swelling, the fluctuant movements can be felt on those two fingers which are used to stabilize the swelling. So Paget's test positivity is characteristically used to demonstrate fluctuation in small swellings. These are non-transilluminant because the content, like I said earlier, are putty-like material. The skin might be free in such cases because the invagination of the ectodermal invagination occurs little deep. There is no skin involvement. Characteristically, they are known to cause resorption and indentation of the underlying bone. When you have an intracranial extension of a dermoid, you can have a cough impulse which might be present. If you have a cranial dermoid, a scalp dermoid, a CT brain and calvarium has to be done. This here you can see a large dermoid which is causing an indentation in the calvarium, in the bone, invading the outer table, but the inner table seems to be more or less intact. Treatment of choice for a dermoid is to go ahead with an excision of it. An excision of it may not be that easy because you find that sometimes the intracranial extensions may not be made out in imaging studies. This is particularly true with regard to scalp dermoids, and we have to be very careful, especially if you are operating on a child with an open frontanel and there's a dermoid located over the frontanel. So there's very high chances that you can injure the dura and can cause CSF leak or torrential bleed. So this here is a person with a scalp dermoid who's undergone an excision and biopsy. So post excision biopsy, you can see here that this skull table seems to be intact. So generally, when you have a scalp dermoid, it is not an ideal swelling to be excised under local anesthesia. Will require general anesthesia because of this risk of having an intracranial extension. A second type of dermoid is a tubulodermoid. Tubulodermoid arises from embryonic tubular structures. It is characterized by the presence of secretions which arise from the epithelial lining of these tubular structures. So these tubular structures are generally tend to get obliterated over a period of time, and if it is persistent, then it leads on to tubulodermoids. Example for tubulodermoids, and the most common example, is a TG cyst or the thyroglossal cyst, which is because of the persistence of a portion of the thyroglossal duct. Other examples would be an ependymal cyst and post-anal dermoids. Third type of dermoid is an implantation dermoid. So implantation dermoids are usually traumatic in origin. Commonly, there will be a prick or trauma wherein the epidermis is buried into deeper tissue, it gets embedded there, and there is a cyst formation. It is acquired in nature when compared to a sequestration dermoid, which is congenital. Here, implantation dermoid is acquired. Commonly seen in areas which are prone for trauma, for example, like fingers in tailors and gardeners, also in the foot. Since here there is involvement, there is a traumatic event which pushes the dermis from the skin, epidermis from the skin into the deeper tissue, the skin is more or less always involved. It is adherent to the skin. Lining epithelium is squamous epithelium, and there are no hair follicles or sebaceous glands here. It is prone for infection, rupture, and pressure defect, particularly in the adjacent vessels and nerves. Excision of it can be done, and it has to be done along with the overlying skin. Fourth type of dermoid are called teratomatous dermoid. So these contain derivatives of all three germinal layers, that is ectoderm, mesoderm, and endoderm. Commonly occur in areas like the ovary, testis, retroperitoneum, and mediastinum. They contain hair follicles, teeth, cartilage, muscles, even bones sometimes. They can be benign or malignant in nature. So this image here shows an ovarian lesion, which is a teratoma. When you have an ovarian teratoma, it is more prone for torsion, and this is a child who presented with acute abdominal pain, and on diagnostic laparoscopy was found to have an ovarian mass which has gone for a torsion along with the tubes, underwent a salpingo-oophorectomy, turned out to be an ovarian teratoma. This is a cut open specimen of an ovarian lesion teratoma showing the presence of hair follicles inside. Another very common swelling is a sebaceous cyst of Venn, you can say. Now, it is a retention cyst. So why do we call it a retention cyst? It is because it occurs because of a block in the sebaceous gland opening. Sebaceous glands can open directly into the skin via their ducts, or they can open into the base of the hair follicle. When you have a block involving this open duct which drains the sebaceous glands, it results in a retention cyst called a sebaceous cyst. Commonly seen in the hair-bearing areas of the body like the face, scalp, scrotum, etc. It is not seen in palms and soles because palms and soles do not have sebaceous glands. The content is usually yellowish, white, cheesy material with an unpleasant odor, and they have a putty consistency. The wall might have a parasite called Demodex folliculorum. The lining epithelium is always squamous epithelium. These are generally painless in nature until and unless there is an associated infection. In 70% cases, you can have a punctum over the lesion located at the summit of the lesion, which is black in color because of keratinization. Now, why it occurs only in 70% cases and not in all cases? It is because in 30% cases, wherein the duct opens into the base of the hair follicle, you may not have a punctum. Characteristically, these sebaceous cysts mold on finger indentation. That is, when you apply pressure, it tends to retain that pressured area or that shape, like how clay molds. When you apply pressure over a clay mold or a clay ball, you find that it holds that shape for some time. That is what happens even in a sebaceous cyst. So this is a picture which is documenting this phenomenon of molding of finger indentation. There is a disease called Fordyce disease, wherein you have heterotopic sebaceous glands in the mucosa of the lip and oral cavity. Usually there is loss of hair over these swellings because of constant pressure over the bulb of the hair follicle, commonly associated with a very important syndrome called Gardner's syndrome, in which case these sebaceous cysts can be multiple in nature. What are the complications associated with sebaceous cysts? The most common complication associated with sebaceous cyst is an infection of the sebaceous cyst, in which case it becomes an abscess and will require a drainage. Sometimes the sebaceous cyst, for the dome of the sebaceous cyst or the summit of the sebaceous cyst, the skin can undergo ulceration with exuberant granulation tissue formation, resulting in what is called as a Koch's peculiar tumor. It is actually a misnomer. It is not a tumor. It is a benign condition, but mimics a tumor because of its proliferative nature. There will be exuberant pain associated with it, and it is commonly seen in the scalp. Now, this here is a very important complication of sebaceous cyst called a sebaceous horn. A sebaceous horn occurs when you have a partial rupture of the sebaceous cyst and the sebum comes out. So, as it comes out slowly, it tends to harden and form a sebaceous horn. Now, a lady with a sebaceous horn is a characteristic image which is seen in the Bailey textbook of surgery. So, it's one of the most important images that you can see in the textbook of surgery by Bailey and Love. Now, scrotal sebaceous cysts. Now, scrotal sebaceous cysts are notorious for being multiple in number. They are commonly seen distinct in nature, calcified, and do not have a punctum. Treatment of a multiple scrotal sebaceous cyst involves partial or total scrotectomy. And they have a characteristic strawberry-like appearance, and hence it's called a strawberry scrotum. So this is an image of a person with multiple sebaceous cysts involving the scrotum. Treatment of a sebaceous cyst is excision biopsy. Now, it is very important that the excision be carried out including the punctum if it is present. The cyst has to be excised in toto. If the cyst is left behind, there is very high chance of recurrence. So, this is one swelling. We make an elliptical incision over the swelling to include the punctum as well, and it is removed in toto. If it is an infected sebaceous cyst, then there is a very high chance that the cyst wall might be retained. So, in such cases, we resort to a procedure called incision and avulsion. So, operating on a sebaceous cyst in the setting of infection, there is very high chance of recurrence. It is to be remembered. Now, another important differential diagnosis for a sebaceous cyst is an epidermoid cyst. It is also called epidermal cyst, keratin cyst, infundibular cyst, or follicular infundibular cyst. It arises from the follicular infundibulum because of epidermal cell proliferation. In neonates and young children, it can appear as multiple superficial cysts, which are called milia. It can occur in the face, trunk, neck, and scalp, and it is caused because of plugging and occlusion of the pilosebaceous unit. It is characterized by increased testosterone levels. Pilar cyst or Trichilemmal cyst are also a differential diagnosis for a sebaceous cyst. Sometimes it may not be clinically possible to differentiate between these three cysts. So, this Trichilemmal cyst arises from the isthmus of hair follicles. They are noted in 10% of population, and 90% cases occur in the scalp. In 70% individuals, it can be multiple in nature, and it is again, like I said earlier, along with epidermal cyst, it is a differential diagnosis for a sebaceous cyst. It is commonly seen in females, particularly middle-aged individuals, and characteristically do not have a punctum.